Everyone. Thank you for joining us today for the Common Causes of Joint Pain in People Over 50 webinar with Dr. Barry. My name is Kelsey with the Iowa Clinic, and I'll be your facilitator today. With that, I would like to introduce our speaker for today, Dr. Kawsu Barry. Dr. Barry is an orthopedic surgeon here at the Iowa Clinic who specializes in joint replacement of the hip and knee. Dr. Barry received his medical degree from the Rosalind Franklin University of Medicine and Science and later completed his residency at Johns Hopkins Hospital in orthopedic surgery. He then completed a year of subspecialty training in adult reconstruction and joint replacement surgery at Harvard Medical School, where he became well-versed in primary, complex, and revision hip and knee replacement surgery, anterior hip surgery, partial knee replacements, the use of robotic, navigated, and custom joint replacement, and outpatient joint replacement surgery. Welcome, Dr. Barry.
Hi, I'm Kawsu Barry. I'm one of the orthopedic surgeons at the Iowa Clinic, as Kelsey mentioned. So I am one of three providers that are orthopedic surgeons here at the Iowa Clinic. My other two partners are Dr. Chris Kim, who does orthopedic sports medicine and specifically treats shoulder, knee, and elbow injuries. And Dr. Kacharian does hand surgery, and Danny and Shauna are physician assistants who assist us with our practices. So the objectives of our presentation today are to describe the common conditions that are responsible for hip and knee pain in patients who are over the age of 50. We'll discuss specific diagnoses under those categories and recommended treatments, and we'll also discuss strategies that maintain bone and joint health at the very end of the presentation. So we'll start off with hip pain, and we'll start off with the hip anatomy, just having a brief overview because it does help provide a reference point in terms of making sense of these causes of pain. So the hip is a ball and socket joint. Think of it as a joystick within a base, and except that it's much more sophisticated with all of the structures that surround it. But that ball and socket configuration allows it to have freedom of motion in all different planes. So the ball part is the top of the hip bone called the femoral head, which is rounded almost like a sphere. And then the acetabulum is the hollowed out part of the pelvic bone. And together, when they are brought together, it's a ball and socket configuration. The ball and socket are both coated with a tissue called cartilage, and cartilage is a smooth, spongy tissue that allows for smooth gliding of the bones with respect to each other with motion. And it almost provides a frictionless type of motion, which allows for it to not feel gritty or feel too bumpy when you're moving across the hip. Immediately outside of the hip ball and joint is a capsule that surrounds the periphery of the ball and socket, and it almost isolates that environment from what is external to it. And immediately outside of that capsule are ligaments and muscles that you see on the right-hand side of this image, on the far left of the screen, that the muscles where they attach to bones are called tendons. And when the muscles are activated or fire, they allow for motion or movement across the hip. And when you bring it all together, the ball socket, the capsule, the ligaments, muscles, they lend support to the joint itself and allow for things like walking, sitting, climbing, being able to swing your legs without even having to think about it. And it's effortless, unless if something goes wrong with any one of these components, which is when you start to notice problems. So it's helpful to categorize hip pain typically in one of two ways. One of them is extrinsic versus intrinsic, and the other is regionally. Extrinsic versus intrinsic is as far as where the origin of the pain is as it pertains to the hip joint and the surrounding structures. When it's intrinsic, it's coming from within the ball and socket, or where the capsule that surrounds that joint is. So anything inside of that capsule that is the cause of pain can be called intrinsic hip pain, versus anything that's outside of it, such as inflammation of the muscles and tendons, is referred to as extrinsic hip pain, or pain about the hip. And then the second way of categorizing hip pain is by location or region, and that's discussed in this next slide. Regionally, it can be frontal, on the side, or in the back. If it's in the front, we call it anterior hip pain, and this is typically around the groin region, and that blue shaded part in the images on the left. Lateral is directly on the side of the hip, and posterior is when it's in the back portion of the hip, almost like in the buttock region. So with respect to pain in the hip that occurs in the front, and I should go back and say that we use the regional method of categorizing hip pain more commonly. As clinicians, it just provides a more useful framework to work off of. And typically when patients come into the clinic, that's one of the first things you want to ask about: what part of the hip bothers you? And when you have that information off the bat, it allows you to start formulating the possible diagnoses as to the most common diagnoses that occur in that part or that region of the hip. And so we'll go through those areas. We'll start off with the front or anterior hip pain. By far the most common reason in patients over the age of 50 with groin or frontal hip pain is osteoarthritis, which we'll talk about in more detail in a little bit. And one of the common ones is a muscle or soft tissue inflammation problem, flexor tendinosis. The flexors are the muscles that cross the front of the hip joint, and they allow you to be able to bend forward across the hip. And you usually would use them, when you're going up and down stairs, or when you're climbing a ladder, or when you're walking uphill. And in general, just with walking, there is an element of your hip flexors that you use. And when you have a tendinosis in them, it's usually due to overuse or a strain, like overdoing it, if you will. And then fracture is lower down on the list as a common cause of frontal hip pain. The way that it commonly manifests is like an elderly female, say over the age of 75 or 80, and they fall and land on that side of the hip. And what would happen in those instances is that you have a fracture across the neck region of the femur, which is the connection between the ball and the ball of the joint and the rest of the thigh bone. That region is very prone and susceptible to fracturing because it's a weak area, especially in elderly females, because they have lower bone density and poor bone stock. And then if you have that injury, unfortunately, it means an automatic surgery, commonly a partial or full hip replacement. You can also have fractures similar to that, except that they are not fractures that you can see on x-ray that break all the way across the bone, but rather they are stress fractures that you can only diagnose by getting an MRI. And sometimes this is not a result of trauma. It can be an overuse type injury. And then lastly is the even less lower down on that list of the common causes of anterior or frontal hip pain is the other category, which includes pain that's coming from the spine, like a low back nerve compression, or you could have a hernia, or what we call referred pain from the bowel or bladder. What referred pain is feeling pain in one part of the body, but the origin of that pain is at a distant site. And so in the case of the hip, you may feel that your pain is coming from within the hip joint, but when it's referred, it's likely from an outside source, and it could come from the spine or bowel or the bladder. Remember, we talked about the ball and socket joint. So these images that you see on the left-hand side of the screen, on the far left is a normal depiction of a hip joint with cartilage on it. The cartilage is this white glistening tissue that you see on it. And you can see that it's coating the ball, it's coating the socket. As it becomes arthritic, what happens is that you have degeneration or a wearing away of the cartilage that this image on the right is trying to depict, such that once it becomes degenerated, if it gets really bad, you have bare bone that's exposed. And when that happens, you have no longer that smooth, frictionless motion, and the bones have nerves on them. And so when you have what we call bone-on-bone contact, where or not even bone-on-bone, but a part of the bone with exposed bone because of the cartilage missing, that motion is no longer smooth, and that repetitive motion across that exposed bone can cause irritation and pain. In the clinic, when we take x-rays of the hip in making the diagnosis of arthritis, this is what it looks like. So on the far left here on the x-rays is what a normal hip joint looks like. What we look at is the space that you see between the ball and the socket there, and that space is normal. That space is filled with cartilage. So the combination of both the cartilage over the ball and then the socket coming together fills this space. As the hip becomes more arthritic, you'll notice on the right-hand x-ray here that that space gets lost and it almost collapses, and then that's when you have what we call bone-on-bone arthritis. And so this image on the right is an x-ray in a patient with severe hip arthritis. So some quick facts about osteoarthritis, just in general, of hips and knees. More than 30 million adults in the US have arthritis. 1 in 4 adults will develop the symptoms of hip arthritis by the age of 85. Half of adults will develop symptoms of knee arthritis during their lives, and more than 80% of people over the age of 55 will show signs of arthritis on an x-ray. Talking further about hip arthritis. So typically, patients will come into the clinic and they'll tell you that they have pain in the groin or the front of the hip. They'll complain of having stiffness, and that will manifest itself in ways like they'll tell you they'll have difficulty putting a shoe and sock on that side compared to the other side. And then they'll tell you that they have trouble with activity. They'll tell you maybe a couple years ago they could walk 2 miles easy without thinking about it, and now they could be able to walk half a mile without having pain limit them. The diagnosis is a combination of what the patient tells you, the symptoms, what you find on the exam, and the combination of the images, namely the x-rays. And usually you piece all of those parts of the history exam and imaging to formulate the diagnosis, which for the most part, it's pretty straightforward. And then the treatment, usually the progression is you start with conservative treatments in the form of activity modification, meaning doing activities in such a way that you're not exacerbating your symptoms, taking over-the-counter medications like Tylenol, anti-inflammatories, and physical therapy. And the goal of physical therapy, which also holds true for knee arthritis as well, is to work on strengthening the muscles that are adjacent to the joint. In the hip, it's the core and the muscles that surround the hip joint. The stronger you get those muscles, the more they help take the load off the joint. So it almost has a buffering effect, if you will. And that can then lead to symptom mitigation in hip arthritis. And then sometimes we do try steroid injections that are delivered into the hip joint space. And it almost has like an anti-inflammatory effect such that it'll help take the pain away, sometimes for 3 or more months at a time. And then if it does work, sometimes we can repeat it. But when we get to the point whereby we've tried all of these treatments and they are no longer effective and the patient is still having debilitating pain that's limiting their activity and quality of life, that's when we then resort to hip replacement surgery, which is a very effective treatment for hip arthritis. As far as the natural history, what that is just the way you expect the disease to progress over time. Arthritis is one of those conditions that unfortunately only gets worse over time, no matter what you do for it. Although there are things that you can do, such as keeping the muscles around that joint strong, that can slow the progression of it down, but inevitably it deteriorates over time, and the more it does so, the more symptoms the patient will have, the more limitations they'll have. This is an x-ray of what a hip replacement surgery after the fact looks like. So this is the right hip here. has a replaced hip. And what that entails when you do the surgery is you remove the ball part, literally by taking a saw and cutting across that neck that I'm referring to here on the right-hand side of the screen. Once that is out, you then put a metal prosthesis in the middle of the bone that is sized appropriate to the patient. And then on the top of that metal prosthesis, there's a ceramic ball that sits on top of it. And then there's a metal socket that you put onto the patient's bony socket. A lot of the time you use screws to hold that socket in place, and then there's a plastic piece that you then and I can go back to this image here, plastic piece that locks onto that metal socket, and then when you piece it all together, it looks like this image on the right, where you have a ceramic bowl articulating with a plastic socket, and that eliminates what was causing the pain, which was that bone-on-bone contact. So that's it for hip arthritis. One of the now we'll transition from going from anterior or frontal knee pain to pain that comes from the side of the thigh. Outside of frontal hip pain, that is a very common, perhaps sometimes even more common complaint of patients in that part of the hip. So this is directly on the side of the hip. And by far the two most common reasons why patients will have pain in that part of the hip are greater trochanteric pain syndrome, also known as trochanteric bursitis, and commonly known as hip bursitis. And the second most common reason is gluteus medius tendinopathy or tear. And I have images on a slide dedicated to that. We'll discuss that a little further. So trochanteric bursitis, one of the most common complaints that we will see patients for in clinic. It's a very frustrating problem to deal with, unfortunately, for both patients and for us, because sometimes no matter what you do, it persists and doesn't get meaningfully better. So patients will come in and they'll tell you that they have pain, and they'll point to the side of the hip. They'll tell you that the pain is exacerbated by sleeping on that side. So they'll wake up in the middle of the night and have to turn over because it wakes them up out of their sleep. They'll tell you that when they sit down for a while and they go to get up, that initial transition is very painful. And after prolonged walking, that also exacerbates their symptoms. And if they have stairs that they take repetitively over the course of the day, it also can be an exacerbating factor to their symptoms. The diagnosis is mostly clinical, meaning it's a combination of the symptoms that the patient tells you about, as well as the exam. So in the clinic, you'll push on the side of the thigh, and that should be the most tender spot of any of the other places that you pushed on their body. And then sometimes the X-ray usually for trochanteric bursitis doesn't show any abnormalities, unless if they have coexisting arthritis. But it's not a diagnosis that we utilize imaging for. But sometimes we do rely on an MRI, which shows you the soft tissue structures better, to help clarify between trochanteric bursitis and the next entity we'll discuss, which is gluteus medius tendinopathy. In that, when it's just trochanteric bursitis, you'll see some inflammation on the MRI in that region. The image on the right explains what the bursa is. So the bursa is this sac of fluid that sits directly on the bony surface, and it helps to cushion the overlying band of muscle called the iliotibial band or the IT band from the bony prominence rubbing onto it whenever you have motion across the hip. Bursitis is an inflammation of that sac of fluid that is depicted on the right-hand side of this image, such that that sac of fluid becomes enlarged, the walls become irritated, and it has more fluid in it. And it's basically an inflammatory process. The treatment for trochanteric bursitis is mostly conservative. Usually for most patients, physical therapy does get them better. That provides them with stretching and strengthening exercises of the adjacent muscles that leads to symptom resolution. Sometimes we do have to use injections of steroids into that bursa sac. And a lot of the time between that and physical therapy, we're able to get patients symptomatic relief. But sometimes, unfortunately, in spite of these treatments, patients will have recurrent symptoms that can plague them for many years. There is a surgical option that's very rarely resorted to. That's when all else fails and the patient is very debilitated, where you go in and you remove that sac of fluid or the bursa sac, and usually your body will regenerate a normal sac again. Then the other common entity other than trochanteric bursitis of lateral or side of the hip pain is gluteus medius tendinopathy. And this is almost deemed to be a continuum of trochanteric bursitis, in that if trochanteric bursitis progresses unaddressed, it can then lead to this problem. So gluteus medius is that muscle that sits underneath the gluteus maximus, which is the big buttock muscle. And it goes from the pelvis, and this is, imagine you're looking at the patient from the side. It goes from the pelvis and attaches to that trochanteric area. So if I go back to this hip, this muscle here, deep to the gluteus maximus, is the gluteus medius muscle, right? Looking at it from the front and then looking at it from the side, that's what it looks like. This muscle functions to help keep the pelvis level when we're walking, and also helps to bring the leg off to the side, called abduction. Some quick facts about gluteus medius tendinopathy. It affects 1 in 4 women over the age of 50, 4 times more common in women than in men. And it has presenting symptoms very similar to trochanteric bursitis. Patients will tell you it hurts on the side of the thigh. It is exacerbated by the same things that exacerbate trochanteric bursitis. And this is one entity that we usually would rely on an MRI to clarify it further. The MRI would show that there is inflammation in the tendons. Again, the tendons are the connection between the muscle to the bone, right? And so it's kind of in this area here. You'll see that on the MRI, it'll be inflamed. And sometimes if it gets really bad, you'll start to see partial tearing, which is the separation of these fibers, these tendon fibers, where they attach to the bone of that tendon. And if it's really bad, you can have a complete rupture of that muscle from its attachment onto the hip bone. The treatment, similar to trochanteric bursitis, is mostly conservative, and this is one that we rely on physical therapy a lot to get it to feel better, and occasionally we would use steroid injections, unless if there is some partial tearing of the muscle. Usually in that case, it's inadvisable to use steroid injections because they can cause they can impede the healing response of your body, and can be counterproductive to your ability of your body to heal it. And then lastly, what pertaining to hip pain, using a regional categorization of the causes of pain, it's the back or posterior hip pain. So the most common causes of having pain in the hip in that region, like usually in that buttock region, kind of a little bit off to the side in the low back, is usually coming from what we call the lumbar spine. The lumbar spine is the lower part of that spine. And a lot of the time that these entities that are listed as subcategories under lumbar spine are responsible for pain in the back of the hip. Axial low back pain, this is just back pain in the middle of the back that is usually from arthritis of the discs, the disc that sit in between the vertebra. And you could also, this could be related to posture over the years, and then strain, meaning you work in the yard and you were bending in an awkward fashion for too long, or you bend down to pick up something and you had poor form in lifting it up. It can cause a strain that can cause pain in that area that can then be referred to the posterior or the back of the hip area. Radiculopathy is when you have compression of a nerve in the low back as they exit the spine, and it'll manifest itself as sciatica, which is a shooting electric shock-like pain that goes from the buttock commonly all the way down into the foot and toes. Stenosis is when you have compression of the actual spine. So the spinal canal is the area within the vertebra where the spinal cord passes through. If you have too much narrowing of that canal, it can cause compression of the spinal cord itself, and that can cause the symptoms that result from spinal stenosis. And the most common symptom that patients would have with spinal stenosis are usually they'll have poor balance, right? All of a sudden they'll tell you, I just don't have the same balance that I used to have before. Compression fracture is a common cause of also having pain that can be referred to that back of that hip area from this is just usually osteoporotic, low energy falls that cause fractures in the spine. And then lastly, the sacroiliac joint, which is the purple shaded area here that can be a common cause of patients complaining of pain in the back of the hip. The sacroiliac joint is the joint between the sacrum, which is where the spine terminates, and the ilium, which is the pelvic bone from the back going up towards the side. So where the two of them meet, it's a joint, and it can become arthritic and can be a source of pain. So we have a lot of time where patients come in complaining of pain in that back of the hip when the pain is not actually coming from the hip joint itself, but rather from something like this. And I should say, though, that there are some patients who would have back of the hip pain, but the cause is none of these that are listed, but in fact, it's from hip arthritis. You see that pattern occasionally, but it's not very common. And then, so a quick word on low back pain. Since it's so common, 80% of people will experience it at some point in their lives. 4 to 6% of those over the age of 65 and over, and women are more likely to experience it than men. And again, it's usually, they'll tell you they have low back pain, goes into their buttocks, they'll have shooting pains like we discussed before. And usually you diagnose it with a combination of symptoms, what you find in exam, as well as imaging. And then, the most common treatment course is usually conservative, combination of physical therapy and sometimes injections. I don't personally treat this when I have patients that come in with complaints that lead me to believe that the source is the low back. Then I would usually refer them to our spine center for further evaluation and treatment. What we do try to clarify, though, is that patients don't have what we call red flag symptoms. Those are signs that you have an acute nerve or spinal cord compression that, if not addressed in a timely fashion, can cause further damage. And this is when all of a sudden you have loss of balance that change from one day to the next. You have weakness in your muscle groups, especially in the legs, and you have bowel or bladder habit changes, meaning like having incontinence of the urine or stool. So that's it for the hips. Now we'll transition over to knee pain. A quick word on knee anatomy. So the knee is a hinged joint, similar to the hinge on a door, and except that it's very, very sophisticated. So it is comprised of 3 bones that come together: the end of the thigh bone, which is the femur, the top of the shin bone, which is the tibia, and the kneecap, as shown in this picture. Similar to the hip, they are coated with cartilage, and when the cartilage is the spongy, smooth tissue that coats the bone ends that allows for smooth motion that is relatively frictionless and allows for that smooth motion. Between the bones, the thigh bone and the shin bone, are these structures called meniscus. 2 of them are called menisci, and they are rubbery pieces of C-shaped structures that sit in between the bones, and they act as shock absorbers between the bones and also help to distribute the weight when you're walking, and they also have confer stability to the knee as well. Then beyond that are ligaments. The ligaments are like very tight ropes that connect bones together, and there are 2 pairs of them that function to keep the knee stable. So 2 of them are in the middle of the knee, called the anterior cruciate and posterior cruciate ligaments. Cruciate because they form a cruciform shape, as you can see here. And these two ligaments work to prevent too much motion in the front to back plane. And the other pairs of ligaments are the ones on the sides. This is on the outside part of the knee called the lateral collateral ligament. And the one on the inside is called the medial collateral ligament. And what they do is they function to prevent too much play in the side-to-side motion. So together, these ligaments almost keep the bones together so they don't fall apart, if you will. And then outside of that are the muscles and the tendons. So the tendons, again, are the muscle attachments to the bone. And when these muscles fire or are activated, they allow for motion across the knee. And this is what allows us to do things like run, jump, squat, dance, and do things, seamlessly without having to think too much about it. And again, similar to the hip, if one part or multiple parts of this go wrong, then you definitely notice. For the knee pain, unlike the hip, where location was a more useful framework to categorize the sources of pain, for the knee, the intrinsic versus extrinsic versus intrinsic categorization tends to be more useful. So the intrinsic causes of knee pain, the most common ones are arthritic knee pain. Second most common would be a meniscus tear, which we'll describe in a little bit. And then a common one that we see, especially more in younger patients, is what's called patellofemoral pain syndrome. And that is just usually a result of muscle imbalance across the knee joint that causes abnormal loading of the kneecap and causes undue pressures on it that then leads to pain. And patients will tell you that they'll notice pain when they're going up and down stairs or when they're going from a seated to a standing position. The common causes of extrinsic knee pain are tendinosis. The hamstring is one of the common ones, which usually they'll tell you they have pain in the back of the knee, and that is just an inflammation of those tendons. Bursitis is a common one, whether pes anserine bursitis, which is on the inside bottom part of the knee, or patella bursitis or prepatella bursitis, which is in the front of the knee. And then referred pain. Again, referred pain, like I explained earlier, is pain whose origin is distant from the site that you're actually feeling the pain. And sometimes one of the common causes of knee pain is actually hip arthritis, and it's referred from the hip. And then patients who have problems with nerve compression in the spine can have referred pain in the knee as well. Knee arthritis, most common cause of knee pain that is intrinsic in patients over the age of 50. Patients will have pain that's localized to the knee. They'll tell you it's hurting me on the inside or outside part of the knee or in the front part of the knee. They'll usually have swelling that is especially exacerbated by too much activity, and they'll have stiffness, and they just wouldn't have the same flexibility that they used to have before. And the pain is usually exacerbated by activity, meaning the more they do, the more they walk, the more they do things, the more it bothers them. The diagnosis, again, similar to the hip, comprises of hearing the patient's history and them telling you the nature of their symptoms, in what settings it bothers them, examining them. The exam is a very key part of it because, and I'll explain this x-ray in a little bit here, you'll see that the arthritis in the knee tends to be isolated to one part of the knee, either the inside or outside. Inside, by far the most common part of the knee. And so you want, if the patient complains of pain on the inside part of the knee, the x-ray shows that the arthritis is more pronounced in the inside part of the knee, then you want your exam to correlate that when you push on that part of the knee, that's where they will feel tenderness, as opposed to the outside part of the knee, for instance. And then, so combining that along with the imaging, the x-ray allows you to be able to make that diagnosis. So the x-rays here on the left-hand side of the screen show on the far left a normal non-arthritic knee, and on the right what an arthritic knee looks like. So the one on the left, you'll notice that this is the end of the thigh bone and the top of the shin bone, And this is the space between the bones that you expect to see in a non-arthritic knee that is filled with cartilage. Again, the cartilage being the cushioning of the bones on both sides of the joint. As the knee becomes arthritic, that cartilage becomes degenerated. And as that happens, the space diminishes. And that's what you see on the x-ray on the right here, where on this patient's inside part of the knee, there is no more cartilage left in this part where the bones are touching. And so now there is no cushioning between the bones. And so when the patient walks and does things, it causes irritation between the bony surfaces that then leads to pain. And you want to see an x-ray that looks something like that. The treatment for knee arthritis is mostly conservative initially, even when the x-rays are, advanced. And that comprises of, similar to the hips, over-the-counter medications, physical therapy to strengthen the muscles around the knee, injections. And injections, they primarily are steroids, and they tend to work predictably better in the knees than they do for hips. And there are some patients that, they have success with the injections for many years before they stop working for them. When all of these treatments are no longer effective and the patient is having debilitating pain that's affecting their quality of life and limiting their activity, that's when you then consider knee replacement surgery, which is a successful definitive management option for this. The natural history of knee arthritis is similar to hip arthritis. Again, it only deteriorates and gets worse over time. There are things you can do to slow the disease process down, but there's nothing you can do to stop it. The far left here shows a schematic of on the arthritic knee and what a replaced knee looks like. It's almost like a resurfacing, if you will. So when you go into the knee, you cut out the arthritic parts of the bone, and it's very thin, bony cuts, just enough to be able to fit in the implants. And so you'll see that this is the thigh bone. This is the metal prosthesis that you put at the end of the thigh bone. And then the top of the shin bone, you'll also put a metal prosthesis. And then on top of that tray that you put on the shin bone, there is a plastic piece that you lock on it. And then you also usually would put a plastic button underneath the kneecap. And that then replaces the bone-on-bone contact you have and replaces it with metal and plastic articulation, which eliminates what was causing that pain, which was the bone-on-bone contact. On x-ray, this is what a replaced knee looks like on the far right, and then the one on the left shows the arthritic knee. And then this is looking at it from the front. Implant at the end of the thigh bone, implant at the top of the shin bone, and the space that you see between them is filled with the plastic. In patients over the age of 50 who complain of pain that's coming from within the knee joint, meaning an intrinsic cause of their knee pain, second most common reason why is usually because of a meniscus tear. This image on the left depicts what the meniscus is. I usually show my patients this picture to explain to them what the meniscus is. I think it helps conceptualize it. So this image here, this is the thigh bone here, this is the kneecap, and this is the shin bone. This is that space between the bones that you expect to see at the level of the knee. And these two structures here are the meniscus. And I showed it earlier when I was talking about the knee anatomy as well. Again, they are shock absorbers. They help cushion the cartilage from further degeneration, and they help give stability to the knee. How this differs in presentation to knee arthritis is patients will usually tell you, similar to knee arthritis, that it's localized to one side of the knee, inside or outside. But it's usually the arthritic pain patient will tell you it's like a toothache. It's gnawing. It progresses with activity. It gets worse with activity. While a meniscus pain tends to be very sharp or intermittent. Patients will tell you, if I'm turning a corner or I'm turning around in bed at night, I put the knee in a position that just causes a sudden sharp grabbing pain that if I correct the knee position, that pain subsides and goes away within seconds, right? This can be accompanied by swelling, and they'll have what we call mechanical symptoms. Mechanical symptoms are things like clicking, catching, popping, or give way, where the knee just buckles out of the blue, and patients will have to catch themselves, or otherwise they'll fall. When those symptoms occur, they are more concerning for a more significant meniscus injury. And usually in those cases, we tend to try to chase it down further by getting an MRI to see how bad a meniscus tear it is. The diagnosis is similar to everything we've discussed so far. It's a combination of what the patient tells you, the examination, as well as imaging. The x-rays don't really show you much because the meniscus is a soft tissue structure that you can't see on the x-rays, but you can see it on the MRI. And so typically when we have a high enough suspicion for it, and the low-hanging fruit conservative treatments are not helping, we then resort to getting an MRI to see if it'll be reasonable to treat it surgically. And then the good news is for the vast majority of meniscus tears, I would say 85–90% of them can be treated successfully, conservatively. And for most patients, that solves it for them. And that's combination of medications, physical therapy, occasionally injections of steroids, and a last resort option, if those treatments are no longer effective, would be doing surgery, which is usually arthroscopic surgery, where you go in with small incisions on either side of the kneecap. You put a probe with a camera attached to the end of it that allows you to be able to see inside the knee joint without having to make an incision to open it up all the way. And then you find that torn meniscus, and typically you're debriding it. You're shaving away that torn meniscus and leaving behind a part of the meniscus that is still intact. And that usually will solve the patient's problem if their pain is purely coming from that meniscus tear. The natural history of the disease is that, unlike arthritis, most meniscus injuries, if you give them a good 4 to 6 months, especially if you do conservative treatments, they get better and no longer become a problem in the future. So that's it for the common causes of knee pain. I wanted to, close off the presentation by discussing some strategies for bone and joint health maintenance. And this is something that I hope that you will find educational in terms of enlightening you on the things that you can do on your part to promote you continuing to be active and healthy into the future. So this graph on the left shows the progression of our bone density from childhood into adulthood. So on this vertical or y-axis is bone density, and on the x-axis or the horizontal axis is time, right? So at the very bottom corner here is when you were born. When you were born, we don't have any bones per se. We just have cartilage, right, which then eventually develops into bone. So we don't really have any bone density. And then as we get older and our bones start to form and develop, the density increases. And it peaks in our early 20s, like between the ages of 25 to 30, right, for both men and women. What you'll notice, the blue graph here is the one for males, and the purple one is the female bone density graph. So you'll notice that, first off, males have a higher peak bone density than females. And when you get to your 25 to 30s, it peaks off there, and then it decreases as we age. And you'll notice that the one for females, unfortunately, when they hit menopause, due to the hormonal changes that occur, they have an even a more significant dip in their bone density than the rate of decline from males, right? So unfortunately, it's like almost adding insult to injury for females. You start off with a lower peak bone density, and because of menopause, you take an even bigger hit, which is the reason why, unfortunately, females tend to be the ones that develop osteoporosis at a higher rate and are prone to have fractures with low energy falls as they get older. So bone density is measured by a study called a DEXA scan. It's usually an X-ray that looks at various areas, including the spine and the hip, and they make a measurement, right? The radiologists make this measurement based on what they see on those images, and what they do then is they compare that to the average bone density of patients who are between the ages of 25 and 30, and then they stratify it, right? So if it's above, -1, that's normal, right? If it's between -1 and 2.5, -2.5, which is what we call the T-score, relative to, again, normal bone density for patients, then it's called osteopenia in that range. And osteopenia is just a significant decrease in the bone mineralization compared to normal. And if it's less than 2.5, it's called that's a diagnosis for osteoporosis, right? Which I'm sure a lot of you are familiar with. And osteoporosis is just a significant decrease in your bone density, and when you have it, unfortunately, it just increases your propensity for fractures, right? Whether it be compression fractures in the spine with very low energy falls, or like hip fractures or wrist fractures with low energy falls, meaning just ground level fall, not even high energy. It's important to ask I've found in my experience here that our primary care doctors are very good at, keeping on top of that by getting a DEXA scan. But if that is not being done by a PCP, for females over the age of 65, they should get it done every 5 years to ensure that, you are not becoming osteopenic or having osteoporosis. And for men over the age of 70, they should also get it done every 5 years. And those would, ensure that, when you make these diagnoses, there are things that can be done medically to help either maintain or build on your bone density, to allow you to be able to continue to have healthy bones. So again, osteoporosis, low bone density, a T-score of less than -2.5. Again, it significantly increases the risk of having fractures, right? Which unfortunately, for all of us as we age, your sense of balance becomes compromised, and so it doesn't take as much if we're not careful to start to have increasing risk of falls. And when we fall, typically, if you land on your side, your hip, the side of the hip takes a good brunt of that force. And in patients who have osteoporosis, it's very common that you'll have a fracture in the femoral neck area. That is as depicted in this image here, and then on this X-ray here, where you have a break between the part we call the neck, between the thigh bone and the femoral head. And when you have this fracture, unfortunately, it means automatic surgery, usually a partial or full hip replacement. And it's usually an urgent or emergent procedure that needs to be done. And in a little bit, I'll talk about the significance of that as far as a prognosis goes. And then one of the other common bones that are fractured is at the wrist. When you fall, you try to protect your head from hitting. To break that fall, you reach out, and as you reach out, you land on your hands, and that force gets transmitted to the wrist and can cause wrist fractures called distal radius fractures, which is a very common fracture we see in the elderly. And like we talked about, because of the fact that osteoporosis is much more common in women, as you can see here, it's a 4-to-1 ratio of females to males. You typically tend to see these fractures and these injuries in females more so than in males. When osteoporosis is diagnosed, it is managed usually by maintaining routine surveillance by way of those DEXA scans. They'll ensure that you're optimally supplemented with calcium and vitamin D, and they'll check your vitamin D levels to make sure that it's normal. And then there are medications that are prescribed for bone density management, like the bisphosphonates, and even newer immunologics that not only help maintain your bone density, but some of the newer medications actually help build bone density, which is great. And then lastly, weight training is one of the best things that we all can do, right? And you're never too old or too young to incorporate resistance training into your regimen. in that, our bodies respond to stress. The more you stress your bones, the more your body responds by fortifying it further by building up that density. And so, even when we're really old, you still have that effect. And then what is very significant about hip fractures is that when you have it, it's one of those things in orthopedics called a sentinel event, in that unfortunately for patients who have it, 25 to 30% of them die within a year. And that's even if it's treated successfully with surgery, but usually that's unfortunately an event that inevitably leads to decline for a lot of patients. And that is a third of patients that die, up to a third of patients that die within a year. And so if you can avoid it in the first place from occurring, it's very, very beneficial. And then I wanted to talk briefly about exercise. So um, we discussed what cartilage is, and the compromise of that is what leads to arthritis. This cartilage decreases the friction in joints. The cartilage itself doesn't have any blood supply to it, right? And the way it gets its nutrition is by way of diffusion of the nutrients from the joint fluid, which is called synovial fluid, which exists in every joint. That is depicted in between the bones on this simplified image of a knee joint, and also from the blood supply that's from the bone. And so the things that encourage that diffusion and keeping that joint fluid fresh and new is usually by physiologic stress. And that's typically things like walking and bending across the knee joint. And in, in, in being able to maintain the nutrition the cartilage needs, you effectively prevent the death of the cartilage, which is what arthritis is. Then lastly, I wanted to talk very briefly about weight management. Maintaining a healthy body weight is important just for your general health, but it also has a significant impact on joint health, especially for the knee joints. So when we just walk on a flat, even surface, for every step we take in the single stand space, our knee joints see 3 times our body, up to 2.5 times our body weight. When you take stairs, that jumps up to 3 times your body weight. When you run, it goes up to almost 6 times. And when you squat, it goes up to almost 7 times, which is a significant amount of force that you're putting across that knee joint. And so, so having excessive weight, patients who are overweight, it does increase their risk of developing arthritis sooner just by way of sheer loading of that joint and the excessive forces it sees. But even for patients that develop arthritis, one of the common ways that we can help mitigate the symptoms of it is, by losing weight. And by losing weight, you're just decreasing how much pressure you're putting on that joint, which then leads to decreased pain. So that's one of the things that we always counsel patients on keeping an eye out for. Quick summary slide on bone and joint health maintenance strategies. So it's important to know your bone density. Request a DEXA scan if your primary care doctor is not keeping on top of ordering it for you every 5 years. Exercise is important, both walking and resistance in maintaining your bone density and your joint health. And no amount is too little. A 15-minute walk is better than just sitting on your couch all day. And work hard to maintain a healthy weight. It does go a long way in preventing or slowing down arthritis and mitigating the symptoms when it does come about. That's all I had for you guys today. Thank you all for your attention and for the opportunity to present this to you all. I hope you found it beneficial. And at this point, we'll be happy to field some questions.
All right, thank you, Dr. Barry. It appears our Q&A feature isn't cooperating, but we have a couple questions here that we can still get to. First is, can hip problems cause knee pain or vice versa, and how are these two joints connected?
Yeah, great question. So hip arthritis can cause knee pain. That phenomenon we call the referred pain, where patients will come in and say, my knee hurts. and then you image the knee, you examine the knee, and you find nothing wrong with it. But you image the hips and you see that they have significant arthritis. You give them an injection in the hip, the knee pain goes away. So that's one common thing that we see. It doesn't work the other way around though. So knee arthritis doesn't cause referred pain in the hip. However, one can cause the other in an indirect fashion, such that if you have really bad arthritis in the hip or the knee that causes you to limp, then that limp causes undue stresses in adjacent joints, and it can cause pain in that fashion.
Great. Next question: if I've had joint pain for a few weeks, but it isn't severe, should I wait longer or come in for an appointment?
Yeah. So, we always make this joke in orthopedics is that if you give most things 6 weeks, they get better, right? So I would use that 6-week rule as a rule of thumb. For most injuries or pains that we have, they usually are a result of overuse. And the reality is, for all of us as we age, capacity and threshold for tolerating activity diminishes. And so, activity that you used to tolerate easily, all of a sudden, can start causing you issues. If it gets meaningfully better such that you're able to transition back to your normal level of activity without any further symptoms, then you don't need to come in for an appointment. But if it persists or if it keeps recurring, then it's often useful to at least come in to get it evaluated. There are a lot of people who walk around with bad arthritis that don't know it. But eventually, it's brought to light one way or another. But I tell patients, you're never wrong for coming in to get something checked out. And sometimes I have patients who have full resolution of their symptoms, but they just are nervous about it occurring again in the future, perhaps because it was so significantly painful, debilitating when it occurred, that it's reasonable to get it evaluated. So you're never wrong for doing that.
Great, thanks, Dr. Barry. We are almost out of time, so I just wanted to point out on the next screen that we have some QR codes for you if you'd like to learn more about Dr. Barry, our joint replacement services, or to schedule an appointment. You can do so with the QR code on your screen or by calling 515-875-9908. Once again, thank you all for joining us today. This webinar has been recorded and will be sent to you in your email in the following days. Thanks, everyone.
Thank you again.